All right, hi everyone, and welcome to my third last lecture video. I can't believe how quick it's gone by. So this is on chapter 13, which means we only have 2 chapters left after this. And just a reminder that your second Healthy Change Journal is actually coming up quickly. So only a couple weeks left to go. Excuse me. So just keep on that, because remember, it is going to take at least a week to do, because you have to do another post-change recording of your health behavior that you had chosen to work on. So I said a bit in my last video, but just to reiterate, so this chapter and chapter 14 just go into certain disorders in much more detail. And then talking about interventions and the impact of certain factors and whatnot on these disorders. So a lot of that I found to be quite repetitive. So like talking about stress in general, we've talked a lot about, and like depression and personality factors and whatnot in general, we've talked a lot about already. And these chapters it's important to go into the detail again specific to these disorders, but just to prioritize and allocate lecture time, I felt it would be a bit more relevant if I spent more time actually just talking about the disorders themselves and the things that hadn't already been covered in other chapters. And like things like CBT, we've talked about in length already. So you still need to know these things, so make sure you read them and you understand them. And if you don't, please ask questions, because it's still very, very relevant. But just in picking and choosing what to allocate lecture time to, I thought it would be probably more valuable to you guys if I went over the things that hadn't been really touched on whatsoever in the textbook yet. So with that, all 4 diseases that are discussed in this chapter involve either the circulatory system and or the metabolic system, and often represent co-occurring disorders, so particularly in older adults. So basically that means it's common to have 2 or more of these disorders together. And you'll see that many have overlapping risk factors, and the risk factors for some are actually like some of the other disorders. So the first disorder that this chapter talks about is coronary heart disease, CHD, and it's the #1 killer in the United States, and it can be attributed a large amount to health behavior factors, like reduced exercise and unhealthy dietary changes. So CHD is a general term. It's not a specific disease, but it's a general term referring to a variety of illnesses caused by atherosclerosis. So if you remember from previous chapters, that's the narrowing of the coronary arteries, which supply the heart with blood and thereby providing the heart with oxygen and nutrients. So when these vessels are narrowed, the flow of blood, and therefore the flow of these oxygen and nutrients to the heart, becomes obstructed and reduced. So temporary shortages of oxygen can produce angina pectoris, which is radiating pain across the chest and arm. But when the shortage is severe, a myocardial infarction, an MI, may result, aka a heart attack. So risk factors include having high cholesterol, high blood pressure, elevated inflammation, diabetes, and behaviors like smoking, poor diet, being overweight or obese, lack of exercise. Because so many of these risk factors relate to health behaviors and things that we can actually change ourselves, prevention by adjusting these behaviors is key and is a huge part to addressing these illnesses. So identifying people with metabolic syndrome can help predict those that are going to be at risk for an MI, for heart attacks. A person's diagnosed with a metabolic syndrome when they have 3 or more of 5 factors related to heightened risk for heart attacks. So when they have obesity that's really centered around the waist, so it's not just if you have excess weight, it's where you're holding it. So if it's centered around your waist, around those really important organs. High blood pressure, low levels of HDL, which is the quote unquote good cholesterol, difficulty metabolizing blood sugar, and high levels of triglycerides, which are related to the bad cholesterol. So, risk factors for CHD and indicators of metabolic syndrome begin to cluster by age 14. So, if you remember that adolescence is when we start to have a bit of a decline in our health behaviors, maybe we're prioritizing other things over our health, because our parents or caregivers may not be managing as much of those health behaviors, and it's put a lot more on us. But we're at an age where we're not really used to doing those things, and other things seem so much more important. So it's a prime area for these risk factors to really start to show up and to cluster together. So, and health compromising behaviors like the diet, exercise, etc. could be developing. However, even though there's a pretty long list of risk factors, there's got to be a bunch out there that we don't even know about yet, because these risk factors that we know don't account for over half of the newly diagnosed cases of CHD. So there's still a long way to go to learn, but working with what we got is the best that we can really do right now. So what do? If you remember that CHD is a chronic condition, and that means it's managed, it's not cured. So one reason for the high rates of mortality and disability following heart attacks is actually delay in seeking help. So unfortunately, people often delay several hours, even up to days, to seek treatment, and this may be due to what the symptoms are and how they're interpreted. So people may have no idea that they're really having a heart attack, and if they don't think they have a heart attack, they're not going to seek help for a heart attack. Many symptoms of a heart attack can be nonspecific, so maybe interpreted as more mild disorders, like maybe gastric distress, like constipation. So people may treat themselves for these disorders instead of seeking medical treatment. Like maybe shooting pain in your chest or your arm, maybe you'll think it's a pinched nerve or you strained a muscle or something. So keeping that in mind, being alone, being by yourself, being older, and African Americans, and those who have consulted with a physician, and or engaged in some sort of self-treatment, self-intervention, these groups are more likely to delay seeking help. These could be attributed to a lot of different factors, like the discrimination a lot of African Americans experience when they come into face with healthcare. Elderly people may have difficulty articulating their distress or even physically calling for help. People may feel as though their issues are already being addressed by themselves or by a physician. So I've already gotten help for it. So surprisingly though, a history of angina and or diabetes actually increases delay. And you would think that when people have these conditions, they're more likely to seek help because they should know that these could be a precursor to a heart attack. But it's possible that they may attribute heart attack symptoms to these symptoms, like it's just my angina again, it's just my diabetes. So what do you do? How do you treat CHD? There's a lot of different options, ranging from surgical all the way down to just some behavioral lifestyle changes. And treatment may depend on the symptoms and the severity of the condition. One invasive option is coronary artery bypass graft, which treats the blockage of the arteries. Following a heart attack, patients are closely monitored in the hospital and their cardiac functioning is closely watched. So you keep a very close eye on these people while they recover to see what damage was done, how they're doing. So understandably, remember personal experience in the textbook and anything like that, how stressful being in the hospital is. I can only imagine, especially right now when you really can't have visitors. So anxiety is super common, and anxiety, understandably then, is really common among people who have had a heart attack. And it can even predict complications coming up in the hospital phase, because anxiety can increase your heart rate, or at least impact your heart rate and your blood pressure. So if you've just had a heart attack, obviously the impact of anxiety can complicate your recovery. So of these complications is reinfarction and recurrent ischemia, which is basically the continued restriction of blood, oxygen, nutrient supply to the heart and the tissues. So instead of things coming back to normal and recovering, there's still pretty much a starvation of the heart. Once that acute phase of illness has passed and the person's then stabilized, education and long-term intervention can begin. So cardiac rehabilitation is an essential component to recovery from a heart attack. And this is the active and progressive process by which people work to regain their physical, medical, psychological, social, emotional, vocational, economic, all of the statuses. Basically get their life back in all the areas that they can. Although they may not return to their pre-attack status, depending on how they're doing, how bad it was, etc., the goal is to have them reach their new optimal level, so as good as they possibly can be now. The goals of rehabilitation are to relieve symptoms, reduce the severity of the disease and the consequences of the disease, and limit further progression of the disease and promote psychosocial adjustment. So your life can change quite abruptly if you have a heart attack, and that requires a lot of psychosocial coping and adjustments in various areas of the life. So rehabilitation programs help to address this as well. So another form of treatment is by medication. And medication regimes for CHD often include beta adrenergic blocking agents, which are drugs that resist the effects of sympathetic nervous system stimulation. So if your sympathetic nervous system, especially if it's hyperactive, if that could possibly accrue another heart attack, or at the very least stunt recovery from a heart attack, this will help kind of depress the SNS a little bit. Like many medications, however, these meds can often come with unpleasant side effects, like fatigue, impotence. So adherence is definitely an issue here. Aspirin is commonly prescribed for people recovering from or at risk for heart attacks because it helps prevent blood clots by blocking one of the enzymes that causes platelets to aggregate. So aspirin will come up again when we talk about stroke. Statins are prescribed for patients following an acute coronary event, particularly if they have elevated lipids. And as stated throughout the text, dietary and exercise adjustments are a staple part of recovering from a heart attack to manage heart disease and prevent future issues. So as I said, I won't go into a ton of detail about stress management, CBT, etc., because they've been discussed by me in detail and in previous lectures, but be sure to go over that. But they are still important components in the co-management of CHD. So with stress management, patients are taught to recognize stressful situations and how to avoid stress as much as you can, and to manage it effectively when you can't avoid it. People may learn effective coping skills, relaxation techniques, and how to problem solve for stressors ahead of time. Because depression is a significant problem during cardiac rehabilitation, people may have lost their previous level of functioning and don't know when it will ever return, if it will return. It poses a risk for treatment success and adherence. Depression is also one of the chief risk factors for rehospitalization following cardiac surgery and death. So CBT for depression is really effective for treating depression and for reducing risk factors for the advancing disease. And as you know, social support is very important for regaining and maintaining health. And social support can predict recovery from a heart attack and long-term survival after coronary artery bypass graft surgery. However, many factors of heart disease have negative impacts on social support. So primary relationships may be threatened because of the strain of the recovery and changes limitations on the person's functioning. So maybe if someone and their partner were very active, and now this person can no longer be as active. So there may be increased conflict that could possibly increase marital strife or like relationship strife, maybe conflicts over changes in lifestyle, activities. Patients may be seen by their partners as dependent and irritable, whereas the patient regards their partners as overprotective. So a bit of a clash in the approaches, the motivations, and the perceptions of each other. Additionally, one consequence of heart disease and heart attacks may be something known as cardiac invalidism, which is a situation where patients and their partners both see the patient's abilities as lower than they actually are. So, especially as the person recovers, there can be situations where you both feel like they can't do that anymore, and even if they possibly could, or they could if you tried. This can result in a progressive decline in self-efficacy and progressive dependence on the partner and social supports that can lead to strain on relationships and the environment over time. Nonetheless, social support is imperative for recovery and to aid the individual before a cardiac event occurs. So, it helps to have them there in the first place. Educating people about the signs of a heart attack, how to differentiate them from those more minor complaints. These can all help reduce that delay behavior and improve treatment seeking if an event occurs, which can improve the person's overall prognosis. So overall, when you think about how well these rehabilitation programs work, they appear to be effective when they target a lot, especially when they target a lot of the adjustable lifestyle factors like weight, blood pressure, smoking, quality of life. By targeting these areas, the risk for heart disease and future hospitalizations is reduced. However, an important addition to these programs is psychosocial treatment for psychological issues. Motivation and self-efficacy are critical for success because you have to feel like you actually can. Otherwise, you won't be quite as successful. And adherence to rehabilitation is variable. So, especially with medication that can have bad side effects, or with the widespread impacts of trying to make a health behavior change. However, the addition of these psychosocial treatment aspects can help improve this adherence. So, addressing these areas can help people stay on track. It can also reduce psychological distress and lower the likelihood that they will experience cardiac symptoms, suffer a recurrence, or die following a cardiac event. So these rehab programs thus far are quite effective, and they definitely could benefit from adding these psychosocial elements into it to make it stronger and to keep people adhering to this rehabilitation program. So next up is hypertension, aka high blood pressure, aka cardiovascular disease, CVD. Hypertension occurs when the supply of blood through the vessels is excessive, putting added pressure on the heart supplying this excessive blood and on the vessels to contain and to carry the blood. So this can occur when cardiac output is too high, so the heart is pumping too much blood, or when there's peripheral resistance, meaning the resistance to blood flow in the small arteries of the body. So for example, if the arteries are clogged or blocked, the pressure could be increased to force the blood through. Although hypertension is a severe issue, it's usually asymptomatic, meaning people can go a long time without knowing that they have the illness, like they have no idea. In addition to its own dangers, hypertension is a risk factor for other severe disorders like heart disease, heart failure, kidney failure, so detection and treatment is important. When untreated, hypertension can lead to impairment in cognitive functioning, such as issues in learning, memory, attention, abstract reasoning, mental flexibility, a host of other cognitive skills. Because if it's pumping too much too fast, if the heart's working too hard, then the brain isn't getting its optimal, proper amount of oxygen nutrients. Remember that systolic is the greatest force when the heart's ventricles contract, and diastolic is the pressure when the heart is relaxed. So systolic has a slightly greater value in diagnosing hypertension and should be kept under 120 for most people. Hypertension may be diagnosed as either mild, when systolic is between 140 and 159, moderate, when it's between 160 and 179, and severe, when it's above 180, like consistently. Unfortunately, most causes of hypertension are actually unknown. So it's not like heart disease where you can track it back to a lot of modifiable factors. Approximately 90% are considered essential, which means it comes from unknown origin. Of the remaining 10%, 5% are attributed to failure of the kidneys, and the other 5 to various other sources. So, although origin is largely unknown, various risk factors have been noted. So, at least if we don't know where it's coming from, we know things that kind of put us at risk, so we can look into those. Childhood temperament, so especially emotional excitability, has been noted as a risk factor. This temperament can promote central weight gain in adolescence. So if you think of this excitability as activating your stress systems, like your HPA axis, and then reducing or releasing cortisol, which can lead to weight gain if it's excessive, etc. And so this weight gain in adolescence in turn predicts hypertension. Blood pressure reactivity in childhood also predicts hypertension in adulthood. Cisgender males are at a greater risk of developing hypertension than cisgender females, but this gender difference appears to dissipate after about age 45. By age 65, cisgender women actually have a higher incidence of hypertension than cisgender men. Genetics do play a role. So if a child has one biological parent with hypertension, then they have a 45% chance of developing it themselves. If both biological parents have hypertension, this risk increases to 90%. So you have a very high chance of having hypertension yourself. Emotional factors, again, are implicated here. Depression, hostility, frequent experiences of intense emotional arousal. And these both predict and can increase blood pressure over time. So they can predict high blood pressure and they can themselves increase. So it could even just make the situation worse. Indeed, the connection between depression and hypertension is actually so prominent that healthcare providers often recommend treatment for depression the second hypertension risk factors are identified. So it's almost just better to provide them with this resource because the connection is so likely and so prominent. Further, cynicism, rumination, so going over the stress over and over again in your mind, and hostility have all been implicated in the development of hypertension. Apparently, I'm not allowed to stop. Understandably, these emotional factors can therefore relate to the family environment. So, a family environment that fosters chronic anger and tension, so if you think back to the high-risk combative families, these are all related to hypertension. In contrast, children who develop competent social skills, so can assert themselves, maintain boundaries, and they can form connections with other people, these have a lower risk for hypertension. And lastly, as with heart disease, stress is a huge risk factor for hypertension. Long-term stress like low SES, migration from rural to urban areas, job strain, these are all related to high risk for hypertension. And the risk of stressors appears to be greatest when these stressors have high demands and little control. So if you think back to workplace stress, when you have a high demand job that you have little control over, that's most likely to be highly, highly stressful. You're stressful. So, moving on, thankfully, there are various treatment options for hypertension. Although people may go a long time without knowing they have hypertension, it's easily detectable with a blood pressure test. So, many may be detected at the pre-hypertension stage, before systolic blood pressure has reached any of those cutoffs for hypertension. In this stage, treatment is usually changing health behaviors, like weight loss when needed, healthy diet, especially controlling sodium intake, and increased exercise. And that can usually keep people from reaching a diagnosable stage. But once diagnosed, hypertension is most commonly treated through drugs, a low sodium diet, reduction in alcohol consumption, increase in exercise, caffeine restriction, and when relevant, weight loss. Caffeine in particular is targeted because it can elevate blood pressure, particularly when combined with stress at the same time. Again, CBT is common to treat underlying psychological issues like depression and anxiety. and to identify cognitive and behavioral areas that could contribute to and sustain this high blood pressure. So think back to self-monitoring. It's not just trying to change anything, it's also just monitoring to see where things are at right now. Further, CBT treatments can be used to combat high blood pressure and even reduce it through those relaxation techniques that are involved. So things like biofeedback, progressive muscle relaxation, hypnosis, meditation, all of these reduce blood pressure by inducing a state of low arousal, activating that parasympathetic nervous system, that rest and digest system, and therefore reducing sympathetic activity. So it's common to add deep breathing and imagery to these tasks to enhance them. Additionally, anger management through CBT techniques is common because of that connection between anger, hostility, and high blood pressure. So do they work? When done, and done properly, yes, CBT treatments have shown success. Of the non-drug approaches, CBT, weight reduction when relevant, and exercise have shown great success at reducing blood pressure. Further, engaging in CBT techniques may reduce the drug requirements for the treatment of hypertension, so you may actually be able to reduce some of the drugs that you have to take. CBT techniques, when they're learned, and they're learned properly and they've been practiced, are quite effective because they can be completed by the individual on their own, and they can be very inexpensive. CBT is a very, of the psychological orientations, it's a very self-driven, self-taught type of modality. Like, it's best when the professional, the psychologist or clinician teaches the person, but after that you're encouraged to go out and do it on your own. So overall, adherence does vary though, because it's so easy to slip away from these techniques and revert back into old habitual reactions. So on average, a combination of drugs and CBT health behavior interventions appear to be the best approach to treating hypertension. Think of it as like the non-drug approaches take care of what they can, and the drugs pick up the rest. This is helpful financially, so you're not 100% relying on drugs, and for people who experience side effects from medication and or don't tolerate the medication well. But unfortunately, as stated, a primary issue is finding out, even knowing that you have hypertension in the first place. Can't do anything about it until you know it's there. Because it's a symptomless disease, diagnosis often occurs during a standard medical exam. Like, you might be at the doctor's for a routine checkup and they go to check your blood pressure and you get a surprise when the results come through. So here's where prevention through education is really key. So many programs have been developed to encourage people to use preventative measures like regular physicals and knowing the risk factors for hypertension. As it says in the textbook, all you really need is an easy blood pressure test to find out that you have it, or at least cue you in to be checking regularly, but you need to at least get that first test. So moving on from the heart to the brain, we have stroke. So like a heart attack is a blockage of blood to the heart, a stroke is a disturbance in blood flow to the brain. Strokes are the 5th leading cause of death in the US, and there's 2 causes of a stroke. Either the blood flow to localized areas of the brain is interrupted, which could result from arterial sclerosis or hypertension. The second cause of stroke is by cerebral hemorrhage. So in this instance, a blood vessel in the brain is actually ruptured, causing blood to leak into the brain. When this happens, large areas of nervous tissue may be compressed against the skull, producing widespread damage and even death, because there isn't a lot of space between your skull and the brain. So the second there's a rupture and the blood is adding to the matter in that space, this is putting a lot of pressure on your brain. A lot of strokes, unfortunately, are fatal, and among survivors, there's a lot of ramifications of stroke. Mobility, cognitive functioning, emotional functioning are often compromised. And a chief risk of stroke is actually the increased likelihood for additional strokes to follow. So it's like if you're prone to a stroke, then you're prone to get more strokes after the first one. So, as with a heart attack, knowing the warning signs is key to preventing any delay behavior that may result in significant consequences. So, again, if you don't attribute it to a stroke, if you attribute it to something else, or you've already sought some sort of health treatment, then you're less likely to seek help. So, here's the primary warning signs from the American Stroke Association: sudden numbness, weakness in the face, arm, leg, especially if it's on only one side of the body; sudden confusion, trouble speaking or understanding; sudden trouble seeing in one or both eyes; sudden trouble walking, dizziness, loss of balance or coordination; sudden severe headache with no known cause. One acronym I actually learned from the Heart and Stroke Foundation is FAST. So F for facial drooping, A for arm weakness, S for speech difficulties, and then T, it's time to get help. So people may not experience strokes in the same way, but these are some major warning signs. And if they're coming up because of the potential severity of a stroke, it's worthwhile to get help, because even if it turns out not to be a stroke, it's better to be safe than sorry. So looking at risk factors, you'll see a lot of these risk factors for stroke actually relate to the aforementioned illnesses, which is why many of them co-occur together. Really, if you look, high blood pressure and heart disease themselves are risk factors for stroke. Additionally, cigarette smoking, a high red blood cell count, and transient ischemic attacks are risk factors for a stroke. Transient ischemic attacks, or TIAs, are known as mini strokes and produce temporary weakness, clumsiness, loss of feeling in a limb or on one side of the body, temporary dimness, loss of vision, temporary loss of speech, difficulty understanding speech. So these can be easily misinterpreted or completely missed, as someone may be spacing out, particularly in the elderly, when cognitive decline and physical capacity decline is going to happen naturally, or you may suspect some dementia or something. Again, negative emotions such as hostility and depression and psychological distress and stress increase the risk of stroke. Risk of stroke increases with age, and it's more common among cisgender men than cisgender women. And it's more common among people with diabetes, among African American individuals, and there are genetic risks for strokes. So with the risk for strokes increasing if there's a family history of strokes. Acute triggers include sudden negative emotions, so sudden stress, such as maybe shock, anger, sudden changes in posture due to a startling event, so if you suddenly get up. In comparison, positive psychological health and positive affect are actually protective against strokes. So the consequences of a stroke are significant, and they vary with the severity of the stroke, the location of the stroke, the person's age, and premorbid functioning, which is how they were doing before they were ill. So someone very high functioning may have a better prognosis than someone who is low functioning. Motor impairments will occur on the opposite side of the affected brain area. So the right side of your brain controls the left side of your body and vice versa. So wherever the stroke is, it's going to impact the opposite side of the body. After a stroke, it's usually difficult or even impossible to move the arm, the leg of the affected side, and the person may require help walking, dressing, completing daily activities, may need to basically relearn how to do these things. So a stroke usually leads to increased dependence on others. And with physical therapy, movement may be regained depending on the severity, again, of the stroke. And even when regained, it may not be as strong, those appendages may not be as strong as they were before, or the movement may not be as fluid or as stable. Cognitive difficulties will depend, again, on the area of the brain that was affected. So on average, left side damage may result in issues with short-term memory and or communication disorders such as aphasia, which is where people have difficulty understanding spoken language and or expressing it themselves, depending on the type of aphasia. Right side brain damage, on average, may result in an inability to process and or use certain kinds of visual feedback. They may be aware of only one side of their face, and, for example, may apply makeup only to that side of their face or shave just that side of their face. Further, they may be unable to understand written language, possibly only perceiving the last part of the word. Understandably, cognitive compromise can interfere with medication and treatment adherence if you have issues with memory or understanding when people tell you when to take the medication or reading the label. Lastly, emotional problems are really common depending on the stroke location. So people with a left side brain stroke, on average, may react to their disorder with anxiety and depression. In comparison, people with right side stroke may experience a condition known as alexithymia, which is where they lack an emotional response and may respond with indifference to their condition. So, obviously, treating strokes is important to return the person to optimal functioning. Interventions typically take 5 approaches: medication, psychotherapy, including treatment for any anxiety, depression, distress, cognitive remedial training to restore intellectual functioning, movement therapies to restore motor capabilities and training in specific skill development, and the use of structured, stimulating environments to challenge the person's capabilities, because you can't do the same thing over and over and over again. You have to have variety and challenge. Although conventional physical therapy isn't sufficient for stroke patients, there is a form that seems to be quite effective. This is constraint-induced movement therapy. And this is where it targets the upper extremities, and this is where the affected limb is used for several hours a day, pretty much ignoring the functioning limb. So like if my right arm was affected, I would pretty much ignore my left arm for several hours of the day and just keep trying to use the right arm. Cognitive therapies, in this case, are focused on helping the person firstly identify their cognitive impairments, because you may not even know right away. They might be obvious, but they might be a bit more subtle and only come up in like the instances when they be needed. And restoring as much of that functioning as possible. And a relatively new area of stroke rehabilitation is something called Neuro Rehabilitation, which actually involves the brain's capacity to restore itself. So the brain, to a certain extent, can actually rewire itself as it heals. The idea here is to let the brain do that, so that areas of the brain other than the damaged areas can adapt and take over for the functions that were previously carried by the damaged area. It may not look exactly the same as it was before, may not operate exactly the same as it did before, but there is evidence to suggest that it is a possible effective avenue of intervention, just letting the brain heal itself. Stroke rehabilitation usually takes months. At first, it was thought that you'll get as good as you're going to get by 6 months, but now we see that people can continue to experience gains years after the event. So especially if you deal with some of the psychological things that could be getting in the way, like increasing self-efficacy, maybe a person now just feels more capable. So the last disorder in this chapter is type 2 diabetes. So type 1, because it's autoimmune, will be discussed in the next chapter. But type 2 diabetes may lead to kidney failure, blindness, amputations of the extremities, and this is known as non-insulin dependent and was previously considered an illness of middle and old age because it's identified as an illness primarily of lifestyle. So attributed to poor diet, low exercise, obesity. So understandably then, with this increase in obesity and sedentary lifestyle and poor diet among youth, the prevalence of type 2 diabetes in youth has increased dramatically at younger and younger ages. In type 2 diabetes, glucose metabolism isn't functioning properly. So glucose metabolism is that balance of insulin production and insulin responsiveness. So how much insulin is made and how useful it's actually being. So as food is digested, carbohydrates are broken down into glucose, which is then absorbed from the intestines into the blood and travels to other organs. So it's our energy. Rising levels of glucose trigger the pancreas to secrete insulin into the bloodstream. With type 2 diabetes, cells in muscle, fat, and the liver lose some of their ability to respond to insulin, known as insulin resistance. So what happens is the pancreas thinks they're not responding, so that means there isn't enough insulin. So it will temporarily produce more insulin, which would be fine if there was no damage of that and it just eventually restored back down to its normal levels. But what can happen is the insulin producing cells can fail because they're being overworked, resulting in long-term a decrease in insulin production. So for a time there's an increase, but then possible damage that happens results in a decrease long-term, so there's no longer enough insulin. Symptoms of type 2 diabetes are frequent urination, fatigue, dryness of the mouth, impotence, irregular menstruation in those with a menstrual system, loss of sensation in the extremities, frequent infection of the skin, gums, urinary tract, pain or cramps in legs, feet, fingers, slow healing of cuts and bruises, and intense itching and drowsiness. So because it's regarded as largely as a disorder of lifestyle, many of the risk factors can be targeted and altered to prevent type 2 diabetes. Unfortunately, this doesn't cover everyone. You have people who are at a very healthy weight that may get type 2 diabetes. You may have people that are underweight that get type 2 diabetes. And then you may have people that are morbidly obese that aren't even pre-diabetic. But it does give us some guidelines for the majority of people to keep an eye on. Risk factors for diabetes include an unhealthily high weight for whatever that person's healthily weight range is, a sedentary lifestyle, again, high blood pressure, a family history of a disorder, having a large baby at birth, actually, being a member of a certain ethnic group. Additionally, the risk for type 2 diabetes increases with age, with the disorder becoming more common among over age 45. So with those ethnic groups, some high-risk groups that are identified are African Americans, Latinos, Native Americans, Asian Americans, and Pacific Islanders. So this may attribute possibly to the cultural way that people live, possibly to the amount of exercise these groups naturally get, or the types of food that they naturally eat, or just due to biological abilities at producing insulin, using insulin, etc. So health implications for type 2 diabetes are quite widespread. Again, this disorder can overlap and increase the risk for aforementioned disorders like heart disease, heart attack, stroke. So in addition to its own implications, it can increase the risk for other disorders that come with their own implications. Additionally, diabetes is the leading cause of blindness among adults and accounts for nearly half of all patients that require dialysis for kidney failure. Diabetes can lead to nervous system damage, so including pain or loss of sensation in the affected areas. So maybe you won't be able to feel like your foot anymore. Or on the other hand, maybe the pain sensors go crazy and you're feeling pain almost all the time. I've known people to kind of describe it similar to when your foot falls asleep and it first wakes up and it's that like shooting pins and needles kind of pain. Foot ulcers or ulcers in the extremities may result, and in extreme cases, amputation may be required. Additionally, diabetes is a risk factor actually for Alzheimer's disease and vascular dementia, resulting in a profound cognitive decline. Increasingly, there's evidence suggesting that Alzheimer's disease is related to poor manufacturing usage, lack of insulin. So as a consequence of all this, people with diabetes have a shortened life expectancy. And within that life expectancy, they have a shortened period of that like high quality life. So however long you live, it won't be as long as someone without diabetes, and the time that is, super enjoyable may be shorter as well. Psychosocially, People with diabetes may have difficulties with sexual functioning, increased risk for depression, cognitive dysregulation, so confusion, memory. Specifically, diabetes is associated with memory impairments. Regarding the risk of heart attack and stroke, diabetes is one of what's known as the deadly quartet. So, intra-abdominal body fat, hypertension, and elevated lipids, and diabetes. These 4 risk factors cluster, and when clustering are potentially fatal because together there's a massive increase in the potential for heart attack and stroke. So, like the aforementioned disorders, diabetes is quite sensitive to the effects of stress. People at high risk for diabetes show abnormal glycemic responsiveness to stress, which may impact glucose production and then consequently insulin production. After diagnosis, stress can further aggravate the disease due to sympathetic nervous system activity. So, when your fight or flight response is triggered, your body's like, crap, I'm in trouble, I need more energy, so then it tries to produce more glucose, which then, or use more glucose, which will impact insulin production. So much of the management for type 2 diabetes is self-administered and involves lifestyle changes. So it can be prevented, and in some cases so controlled that the person's no longer considered diabetic. I mean, I'd assume that's the exception and not the norm, but I have known people to have their diabetes, type 2 diabetes, so controlled that they're no longer even pre-diabetic. This is done by reducing sugar and carbohydrate intake, maintaining a healthy weight, depending on where they were to begin with, engaging in regular exercise. So if you think all the way back to talk about diets and, my little rant about how much I hate diets and use of the ketogenic diet as an example, some diabetics benefit from these super low carb, low sugar diets like the ketogenic diet because of the reduction in carbohydrates and sugars. Unfortunately, adherence is problematic because these changes require a good deal of self-control. And when you think back to talk about everything has its limitations and its costs. So maybe you really like sugar or you really like carbs and, you can't eat that as much anymore. Like I have a colleague that's an Italian and, if they couldn't eat bread anymore, I don't know what they would do with themselves. Or pasta. So, there can be a lot of widespread changes that are really difficult and not so fun. So, it can also require not just self-control, but access to potentially expensive resources as well. So, to improve adherence, CBT interventions, again, have shown success, improving self-control, self-management, problem solving. These have all shown promise, particularly considering much of adherence issues arises from running out of medications or forgetting to take them, especially if there's any memory impairment from the diabetes. You have to remember that your medications are low. You have to remember to take your medications. Problem solving, like you still want to be able to go out for dinner again, for example, with family, and problem solving so that you're not tempted to just order food that you used to like, or problem solving so you know what you can eat and where. Additionally, social skills training is really useful here, particularly to maintain those lifestyle regimens, again, necessary to control diabetes. So for example, explaining to people that, I can't eat at this restaurant, or I can, but I can literally only eat one thing. Overall, like lifestyle interventions in multiple areas, in addition to medication. These are all kind of that gold standard approach to reducing the incidence of diabetes, controlling it when it's diagnosed, and even preventing it altogether before it comes up. So with that is the end of chapter 13. So then we only have 2 left to go. And in my next video, I'll probably give a bit more detail into your final exam. It will still be multiple choice. And if you recall, it's at the end of August. But you're going to have, I believe it's the 28th. I don't have my notes in front of me, so if I'm wrong, go by whatever I've said before or whatever's in your UInsight. But just remember that it probably did give you a time range. Like I think it gave like 3:30 to 6:30 or something. But you're going to have 12 hours, so it's going to be available from like the morning to the nighttime. All right, so otherwise, get cracking on your healthy change journal. Reach out to me if you have questions, and I will see you next week. So take care, everyone.